Very good, guys. I think what we'll do now is I'm going to go over to my first guest in the Rehab Power Hour today. I have Brian and Patricia with me. Welcome, Brian and Patricia.
Thank you.
Hey, guys. So if you wouldn't mind, I know you are new users, and I have some questions about some of the systems that you're using, the Motus Hand. But would you mind, before we get into those details, would you mind just introducing yourself? Tell me who you are, where you're calling from.
We're calling from North Kingstown, Rhode Island.
Okay.
And I had a stroke about 3 months ago, and I lost the use of my right side. My legs have come back, but my right arm is not.
Okay.
My fingers are not working, and I cannot lift my arm up to shake your hand. So,
Sure. Well, Brian, in terms of, oh, go ahead, Patricia, go ahead.
No, I was just going to say the neurological pain is severe in his hand and wrist.
Yeah, exactly. I think this is the main thing that I wanted to talk with you guys today, and that is you guys jumped on that aspect of my version of rehab, and that is that despite the old baggage of that rehab or PTs or OTs may have imparted on the world, it is not supposed to be painful, right? It's not supposed to cause tissue damage. And I'm drawing a distinction there because pain as a result from tissue damage, either working too hard or moving in ranges of motion that are not okay, can of course cause tissue damage, and we want to avoid that. Now, I'm going to draw a distinction between that and neurologic induced pain. And this is very, very common following stroke and is especially common after what are called thalamic strokes. So the thalamus is a deep structure inside of our brain that handles a lot of sort of gatekeeping activities with respect to sensory information and how that is coordinated for various other aspects of perception. And one thing I might just add here is a bit of note about pain itself, right? Pain is all inside of our heads. There are sensors out in our periphery that actually detect pain normally. And those are very, very evolutionarily important, right? We need to avoid pain such that we don't have tissue damage. But after neurologic injury, often what can happen is sensations that prior to injury are not painful or uncomfortable can be misinterpreted as painful. For example, sensations such as hot and cold, light touch, or pressure, or even movement can be interpreted as being painful. Now, this is, like I said, it's very, very common after a thalamic stroke, but it can also happen after sort of typical MCA strokes. It's a little less common, but it is certainly possible as well, where effectively there's no necessarily indication of damage in the periphery, but those sensations that would normally tell, hey, my hand's being touched, or I'm experiencing some movement, those things, that information can get interpreted as a painful stimuli. And so, go ahead. Question? Ooh, okay, it looks like we have some background there. That's okay. Well, Patricia and Brian, any kind of thoughts on that description so far?
No, that's excellent because he's had his hand x-rayed by a stroke neurologist, and we've been stroke surgeon, and we've been through, everything. And they say there's no damage other than the neurological. There's no muscle damage or anything like that. So my concern was
no arthritis.
There's no arthritis, there's nothing. So him using this device has seemed to be quite good for him, and he's only been using it less than a week.
Sure. So yeah, and I think
it continues.
Yeah. So let me talk about this really quickly. And so this sounds really quite bad, right? This idea of how these senses, these sort of sensory signals are being misinterpreted, and it can be very, very challenging, right? It can be very, very troubling. And now I should maybe emphasize this, that just because they're not due to tissue damage, like if I cut my hand, that's going to send a signal to my brain that, ow, it hurts, right? Now that perception that I'm experiencing is as real as the misperception or the misinterpretation of the signals that you might be experiencing with your post stroke pain. Those two things are equivalent, right? It's your perception is as real as the tissue damage. So I'm not trying to say it isn't real and it isn't something to recognize. Now,
No,
the distinct, yeah.
No, my point was that I'm glad that he's going to be able to use this device.
Yeah,
Because-
yeah, and I think what I'm drawing a distinction here, and that is I want to recognize that it is very real. Your perceptions are very real and they're very important, but the way we actually interact with them and we try to improve them are very different, right? There's actual tissue damage. We need to modify things to avoid ranges of motion, to avoid movements that might cause that. For instance, if there was actual muscle strains, or if there was a bone damage or neurologic damage itself in the peripheral nerve, we would have to modify things to not have further tissue damage. Now, if it is purely an interpretation of that information as being painful, we need to handle that differently. We need to recognize that pain and try our best to leverage some techniques that can desensitize your normal perceptions. So it's very much like if you're trying to relearn how to move your arm again or to move your leg again, we have to do very much the same thing with those sensory systems, right? We have to slowly and gently expose ourselves to low levels of those sort of senses such that we are able to accommodate and recognize that, hey, this normal sensation that is just pressure or touch or cold or hot is not actually damaging my tissues. And as I kind of already sort of hit the punchline there, the term is really desensitization training or acclimatization. And the way we have to do this is still especially careful because despite the fact that it isn't necessarily tissue damage, it is still disconcerting and can be very, very uncomfortable. And so we want to do it in a very, very controlled and slow manner. And so one thing for you guys that we need to do is we need to recognize where the movements are that you don't have pain. You can imagine it being kind of like a sphere, right? And let's say I could quantify all of my movements that I can do in this sphere that don't cause any pain. But at the moment I try to move outside those boundaries, or that sensation starts to go above that, I start to perceive pain. So what we have to do is we have to be very honest with ourselves and recognize where those boundaries are of pain, my perception of pain, and work up to those points. And we need to spend some time in those areas where it might have a mild sensation of discomfort such that we can begin to normalize those things. And very much like the motor recovery, the sensory recovery can be very, very robust and very, very positive. It just takes some time that for it to actually adapt.
His pain really is even just due to touch.
It moves.
Sure.
But at times, I can move my finger like that much, and that will kill me. Other times I can move
A little
quite a bit.
more. Yeah.
Yep. And the inconsistency is very, 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 I'd say complex to deal with, right? And I think what you need to do is we need to recognize when we have good days, and we need to capitalize on those good days when you do have that capacity to move.
Most of the pain comes in at night.
Okay.
7 o'clock, 8 o'clock at night. That's when it starts getting really bad.
Sure.
In the morning, it doesn't hurt because I'm not using it as much and I have it elevated. But at night, it seems to swell more and have more pain.
Sure. Yeah. And I think that can help inform how you actually decide to use your Motus hand in this case, right? If we have more leeway earlier on in the day, prior to that late night complication, then we might want to devote more time earlier on to the rehab approaches when you have the ability to move more and it's going to be less discomforting to you, because we really need to capitalize on this time, right? You're 3 months post-stroke. It's a great time for you to start your recovery, and we need to use this time as best we can. So I would say that we can reorganize or reorient as best you can the intervention such that they're in a time when you're not going to have as much discomfort. And then when you do find yourself in those timeframes when you're having some discomfort, maybe even doing some light touch, doing some light hand mobilizations to yourself, right? Where you're doing some skin touching, some exposure there can really help to start to beat back those perceptions of discomfort. Of course, don't push it too far, right? Because that can cause problems, but we want to slowly build up that reservoir, that capacity to take those normal sensations.
All right.
So do we have to, he's using the machine, the device, he's
Mhm.
using it quite a bit. Is there some way that we need to dial it in, or are we just pretty much doing what we did, what the device is telling us?
Yeah, so right now I'm looking at the data. Things look reasonable right now in terms of the ranges of motion, the movements. I'm seeing some nice changes in ranges of motion, which are good. And what might be useful is we've got a good baseline here, and maybe in a week or so we can come back on and do a formalized assessment where we evaluate those ranges of motion from where we started to that assessment. We can get a nice view of
Great.
where your progress is.
Okay, that's wonderful.
Yeah. So how does that sound?
That sounds good. Thank you.
Very good.
So-
And so what we'll do is we'll be sure to reach out to you guys and get you
Okay.
scheduled for a formalized assessment. And hopefully that will happen next week or so. And that way
Okay.
we can kind of touch base and get all of those details figured out.
Okay, wonderful. Thank you very much. You've answered all of our questions.
Great. Yeah. I'm so happy to have met you guys, and so happy to be useful. Let's put it that way. So I'm really glad.
Have a nice day. Thank you.
You too.